As I have told you yesterday, that the day before yesterday, that ankle injury is due to violence or twist. All right. When the foot is grounded, as in a hole or in the ski board bend. So the foot is grounded and the momentum of the body causes the injury to the ankle. All right. Or sometimes you may stumble on an unusual obstacle or in the moving downstairs or upstairs. All right. The injury is typically classified as external rotation injury, internal rotation injury, and the vertical compression injury. External rotation injury, internal rotation injury, and the vertical compression injury. Now, as per orthopedic rule, that you have to see, look, feel, move, and measure. These are the 4 dictums of observing or examining a case of orthopedic injury, right? Palpation for local tenderness or something, warmth of the area, unevenness, all these things comes under palpation. Arterial pulsation, all right. Movement is, now as there is injury, so the movement will be automatically restricted. Now you need to observe which movement and what is the range of the, which movement is present and what is the range of the movement present after the injury, all right. Now how we examine the movement? We hold the ankle or the lower end of the tibia fibula, lower end of the leg with one hand, and the foot is rotated like this with other hand. This is the method we follow to see active and passive movements of the ankle joint. So look, feel, move. Now measurement is not very much important in case of ankle joint. Measurement doesn't help too much, all right. Only that if you measure from the back of the heel, if you measure from the back of the heel to the medial malleolus, then to the ball of the great toe. Similarly, from the point of the heel to the lateral malleolus to the base of the head of the metatarsal of the fifth toe. All right. This will give you the distance between the point of the heel to medial malleolus or the point of the heel to lateral malleolus. These distances are reduced in case of calcaneal fracture. These distances are reduced in case of calcaneal fracture. All right. Now the thing is, another thing is that when we do X-rays, AP view and lateral view will suffice. We call not X-ray AP view, we call it dorsiplantar view. All right. Now there is another view, that is another attempt, that is if you hold the ankle in a stretched position, either in the medial rotation or lateral rotation, there will be ligamentous strain, and if there is any fracture, that will be exaggerated, and this view is called positional sciagram. This is called positional sciagram. All right. Now about the injuries. Now first thing is, how do we explain inversion and eversion? Inversion and eversion. Inversion and eversion takes place in the mid-tarsal joint, that is the talocalcaneal, write down. Inversion and eversion is observed in the mid-tarsal joints, that is the talocalcaneonavicular and calcaneocuboid joint and the subtalar joint. All right. What is inversion? Inversion is the raising of medial border of the foot. Raising of the medial border of the foot with plantar flexion. All right. And eversion is raising of the lateral border of the foot with dorsiflexion. Of the foot. All right. But inversion and eversion is related to adduction and abduction also. All right. Inversion means plantar flexion, adduction and lateral rotation, that is supination. Inversion equal to 3 movements, that is number 1 plantar flexion, number 2 supination or lateral rotation. Supination or lateral rotation. And this is inversion. And eversion is dorsiflexion, abduction, and medial rotation. It looks query that if you do not try to do this in your foot, this is raising of the medial border. All right. Now it is related to supination. Supination means the foot is trying to supinate. All right. And with the supination, there is lateral rotation of this subtalar and the mid-tarsal joints. These bones are turning to the lateral aspect. These bones, that is the bones of the mid-tarsal joint and the subtalar joint are turning laterally. So there is lateral rotation. All right. This is inversion. And similarly, foot is plantar flex. Similarly, in case of eversion, you will see the raising of the lateral border of the foot. All right. The foot is dorsiflex. The foot is dorsiflex, and there is medial rotation or pronation of the mid-tarsal bones of the mid-tarsal joint and the subtalar joint. All right. You have to practice it, and you will understand the inversion and eversion. Remember, inversion and eversion acts as a single unit when you consider, okay, thank you. The inversion and eversion acts as a single unit when both these joints of these bones are connected by the bifurcated ligament, are joined by the bifurcated ligament. All right. Now, you have read the tibial components of the tibial nerve, muscle supply of the tibial nerve and the common peroneal nerve. What are the inverters and everters supplied by the tibial nerve and the common peroneal nerve? Because injury to common peroneal nerve and foot drop is a regular question. Injury to common peroneal nerve and tibial nerve in relation to inversion and eversion is a very common explanatory note. All right. Now, can you remember the popliteal fossa? All right. The upper two corners are made by the medially by the semimembranosus and semitendinosus. All right. On the lateral aspect, there is short head and long head of biceps. Short head and long head of the biceps coming up to the tip of the posterior aspect. On the posterior aspect, the tip of the fibula. All right. And on either side, we see on the femur, lower end of the femur, we see the lateral and medial head of gastrocnemius, and there is plantaris. All right. Below we see the popliteus, and the soleus. Can you remember all this structure? And the sciatic nerve, what is the root value of sciatic nerve? What is the root value of sciatic nerve? Ventral branches of ventral rami of L4, L5, S1, S2, S3. And that is for common peroneal nerve is dorsal branches. There is the dorsal branches of the ventral rami of L4, L5, S1, S2. You have to remember these two things throughout your whole of your medical course. This is tibial nerve and this is the common peroneal nerve. All right. So, the sciatic nerve divides into two at the junction of mid 2/3 and the lower 1/3. All right. The tibial nerve runs in the midline passing over the popliteal vein and the popliteal artery and gives it branches. The nerve gives branches on its lateral aspect. Medial aspect of free except for the medial head of gastrocnemius. All right. And the common peroneal nerve appears at the neck of the fibula. And it pierces the peroneus longus. And passes in between the peroneus longus and peroneus brevis. All right. And in the lower third, it divides into superficial peroneal nerve and the deep peroneal nerve. All right. This you know, as I believe, this you know. Now the peroneal nerve, that is the deep peroneal nerve. Superficial nerve gives the cutaneous supply. The deep peroneal nerve supplies the peroneus longus, peroneus brevis, as well as the peroneus tarsus. All right. Now the tibial nerve supplies. What are the muscles tibial nerve supplies? That is the tibialis anterior, the flexor digitorum, extensor digitorum longus, extensor hallucis longus, tibialis anterior, and all the muscles of the foot except extensor digitorum brevis. So, when there is a severing or cut in the tibial nerve, there is the attitude of the foot is one of dorsiflexion. When there is severing of the tibial nerve, all right, there will be no supply to the flexor component, that is the back of the crura, that is the popliteus, soleus, gastrocnemius. All these muscles will be cut. Their supply will not be from tibial nerve. All right. Only the anterior fibers to this flexor, anterior fibers to this extensor, digitorum longus, extensor hallucis longus, and tibialis anterior will remain. Right. So the attitude of the limb will be one of dorsiflexion. All right. And in case of common peroneal nerve injury, that is the deep peroneal nerve injury, you will find there is foot drop. Here the anterior muscles are working intact. And in case of common peroneal injury, there is severing of the fibers to the extensor group of muscles. Only the flexors are remaining. All right. Now remember that when in dorsiflexion of foot, you try the dorsiflexion. You will find your ankle joint is tight. This is called close pack situation of the ankle. When the foot is close packed, there is much stability. And when it is close packed, we take the heel forward for locomotion, forward locomotion. All right. And in case of loose pack, when you plantar flex the ankle joint, you will find your toes are to the ground. This is for running on the toes. This is for running on the toes. So dorsiflexion makes the joint tight, that gives stability to the joint, and plantar flexion gives the toes, makes the toes to stand on the ground for running or fast running, fast walking. What my point? Now one thing is very important. Nowadays, the modern ladies wear the high heel pencil cut shoes. Now what is the utility of this? Can one say, my dear ladies? Did you ever understood why we wear high heel pencil cut? Can you pode bolo? খারাপ আগেনি পেন্সিল কাটটা খারাপ আগেনি তাই না কিরে খারাপ আগেছি তো দিস হাই you imagine this number one your foot is plantar flex isn't it as I have told you the dorsiflexion makes the foot stable, but it keeps you on the ground, not for running or not for fast walking, because it will prevent the side shifting. The dorsiflexion it is anchored to the ground, it prevents side shifting, but it will not allow you the forward stride of the walking or running. All right, but when the foot is plantar flex, the joint is loose packed. There is enough space for joint fluid to spread into the cartilages and the surrounding structure. Right? And you can run or walk fast as your toes are on the ground. Right? But there is a chance of side shifting. It may skid side to side. All right? As there is much space, there is loose packed joint, there is enough joint fluid that nourishes your ankle joint. Together with this position of your foot causes tonic contraction to prevent forward skidding. There is tonical contraction of the tendocalcaneus. This plantar flexion causes enough joint space to nourish the cartilage and the other joint structures. Right? So when you fix the ankle joint due to some injury, ankle joint ke fix korle ki korbe? Flexion e korbe, dorsiflexion e korbe na plantar flexion e korbe? What will be the position of the ankle joint if you fix the ankle joint due to some injury? Definitely it will be plantar flex, because there will be enough joint space to nourish the ankle joint. Together with, there is an opportunity that it prevents the tonical contraction of the soleus gastrocnemius, that is through the tendocalcaneus. It prevents the forward skidding. And in case of the girls, what happened? This tonical contraction of the gastrocnemius soleus through the tendocalcaneus. What does it causes? With the very smooth and rounded contour of the calf muscle. That looks beautiful. That adds beauty to their legs. Got my point? The forward skidding is prevented by the tonical contraction of the gastrocnemius, soleus and the plantaris, and it causes the shaping of the calf muscle into a smooth and rounded contour. Done? Alright. Now come to ankle injuries. Now you see, as I have told you, that is the Lauge-Hansen classification. Lauge spelling is L-A-U-G-E and Hansen is H-A-N-S-E-N. Lauge-Hansen classification, and there is Weber B classification. Alright. The basic thing is that the first stage of joint injury is the ankle sprain. First stage of joint injury is the ankle sprain. You test for ankle. How do you test for sprain of the ankle joint? If there is pain below the medial or lateral malleolus. If the pain is below the medial and lateral malleolus, and it increases by external rotation or internal rotation, that is, it will cause stretching of the ligament, collateral ligaments of the joint. So this is ankle sprain, right? This is the first stage of ankle injury. Next is the external rotation injury, then abduction injury, then adduction injury, then the vertical compression injury to the tibia, then the injury to the calcaneum, alright, then injury to the calcaneum. Now you see, in case of external rotation injury, there is a spiral fracture in the, this is the stage 2. There is spiral fracture of the fibula. Stage 3, there is avulsion fracture of the medial malleolus. This is stage 3. Stage 4 is the fracture of the posterior malleolus. Posterior malleolus means that is the posterior part of the lower end of the tibia. Alright, where the tibiofibular interosseous membrane, interosseous ligaments are attached. That is called tibiofibular diastasis. Alright. So the first one is the spiral fracture of the fibula. A is the external rotation injury. This is external rotation injury. The first is the spiral fracture of the fibula. Next is the due to tonical contraction of the fibers of the deltoid ligament. There will be transverse avulsion fracture of the medial malleolus of tibia. Alright. And then there will be fracture in the posterior malleolus, that is the lower part of the posterior part of the tibia, with tibiofibular diastasis, means there will be opening of the, due to tearing of the fibers, this tibia and fibula will separate widely. That is the tibiofibular, inferior tibiofibular diastasis. That is the external rotation injury. Now the abduction injury. In case of abduction injury, the fibular fracture is 2 inches above the ankle joint. The fibular fracture is around 2 inches above the ankle joint. Right. This is followed by the avulsion fracture of the medial malleolus. Then, if the rotation is continued, there could be fracture in the posterior malleolus. Right? This is the abduction injury. Now, in case of the vertical injury, you see there is along the lateral border of the tibia, there is a vertical fracture. This one. Alright. And if with continued injury, continued rotation, there is fracture in the tip of the fibula, lateral malleolus. All right. Now, how to see the calcaneal injury? For X-ray of calcaneal injury, we need axial X-ray. What is the axis of rotation in the talocalcaneonavicular joint, calcaneocubular joint, calcaneocuboid joint, and the subtalar joint. All right. Now we draw two lines. We draw two lines. Number one, along the medial and lateral, articular and non-articular surface of the calcaneum. Articular and non-articular surface of the calcaneum. If I draw from the point of the heel, one line from the point of the heel toward the lateral side of the joint. All right. This forms the axis of rotation of calcaneum and talus. All right. And these two lines, point of the heel along the medial aspect and along the lateral aspect. The angle between the two is called the tuber joint angle. That one is the tuber joint angle. I don't have the blue, so I missed the blue marker. So I missed the here will be one cartilaginous part and here will be also a cartilaginous part. Right? When the tuber joint angle is normally 40 degree. In case of cross fracture of calcaneum or split fracture of calcaneum, there are two terms. What is cross fracture and what is split fracture? Split fracture means along the axis it is divided, separated. All right. The two parts are separated, the lateral part remaining larger. All right. And what is cross fracture? Have you ever seen vertebral fracture? Vertebral fracture দেখেছো? এইগুলো দেখো vertebral body. All right. When there is a fall from height, what happens? The vertebral body is compressed. This is compression fracture or the cross fracture. All right. Similarly, the calcaneum will be compressed and the talus will be directed downwards. This is crossing. What my point? And split means it is split into a lateral fragment and a medial fragment, where the lateral fragment is larger. All right. And similarly, obviously, if the talus is depressed downwards, there will be reduction in the tuber joint angle. There will be reduction in the tuber joint angle. Along with this, you need to know, number one is the fracture in the metatarsal. You remember that metatarsal bones are usually fractured at the base. Metatarsal bones are usually fractured at the base. All right. Except the second metatarsal has got more fixity. Its movement is very much restricted. Its movements are very much restricted. So, in case of continuous stress for marching over a long distance for the soldiers, there is fracture at the neck of the second metatarsal bone. This is called march fracture, M-A-R-C-H. This is called March fracture. And fracture, you very commonly come, the ladies very commonly come with pain at the base of the fifth metatarsal. This fracture, that is the fracture at the base of the fifth metatarsal, is known as the Jones fracture. Done. So, supply to the muscles around the joint through the tibial nerve and the common peroneal nerve. Then injury to the tibial nerve, that is the dorsiflexion. Attitude is the dorsiflexion, and in case of common peroneal nerve injury, there is foot drop. And together with the sensory loss, as we have been earlier taught. Now, only one thing is left that is not very much needed, of course, for you. That is giving the joint from before backwards. What are the joints in the foot? Alright. If you were given the articulated foot in Vivavosi, alright, then you will be asked, what are the joints from before backwards and what are the types of these joints? Alright, you have to tell what the type of joint. That is, first is the interphalangeal joint. First is the interphalangeal joint. What kind of joint these are? These are hinge joint. These are hinge joint. Alright. This moves like this. This is the interphalangeal joint. Alright. Next is the metatarsophalangeal joint. This one is the metatarsophalangeal joint. This is an ellipsoid joint. Alright. And you will see the plantar aspect of this joint has much more articular area. Alright. So this moves like this. This comes towards the plantar aspect and again it goes back towards the dorsal aspect. So this is an ellipsoid joint. Right. Then there will be transverse tarsal joint. Transverse tarsal joint is the calcaneo-navicular joint and the calcaneo-cuboid joint. Write down transverse tarsal joint. In case of intermediate, then calcaneo-cuboid joint. Then comes the subtalar joint. So 3. There is a joint between the medial cuneiform to the first metatarsal. Now from the lateral malleolus to the cuboid. And there is a complex cavity in between the calcaneo-navicular, cuneo-navicular, intercuneiform, alright, along with the bases of the metatarsals and adjacent surface of the metatarsal. This is not very much important in defining it. Alright, just remember there is another joint that makes the total count into 6. Alright. And in case of tarsometatarsal joint, though there are 5 joints, tarsometatarsal there will be 5 joints, but the first joint remains in a separate cavity. Second and third accumulates to form a separate cavity. Fourth and fifth metatarsal accumulates to form another cavity. So, though the number of metatarsal, the joint tarsometatarsal joints are 5, there is ultimately 3 cavities. Alright. And as I have described, the metatarsal joints are number 1, calcaneo-navicular joint, calcaneo-cuboid joint, the subtalar joint, together with the medial cuneiform to the first metatarsal, lateral cuneiform to the cuboid. Alright. And there is a complex joint cavity including the intercuneiform, cuneo-navicular, cuneo-cuboid, internavicular. All this forms a single joint cavity. Thus makes the count 6. Kota holo? How many? The transverse mid-tarsal joint or the transverse tarsal joint, that is the talo-calcaneonavicular joint and calcaneo-cuboid joint. Then comes the subtalar joint. Alright. Then from the medial cuneiform to the first metatarsal, from the lateral cuneiform to the cuboid. 3 to 5, and there is a complex cavity of the intercuneiform, calcaneo-cuneiform. Alright. And with the metatarsal. So in total there are 6 joints. Done? Alright. Now there are only 3 things that you need to know: the dorsiflexion and the plantar flexion. Alright. And only a little understanding of the inversion and eversion of foot. As I have told, inversion and eversion acts as a single unit when the bifurcated ligament fixes both of them. Bifurcated ligament fixes both of them. As I have told you already, that in case of talo-calcaneonavicular joint, the plantar calcaneonavicular ligament is called a spring ligament. Can you remember? From the anterior aspect of the sustentacular tali to the undersurface of the navicular, on which the globular head of the talus gets supported. Alright. And within this ligament, on the upper surface of this ligament, there are some cartilaginous plates, and below there is a tendon of the tibialis posterior. Alright. When you stand on, this ligament is stretched. When you stand on, this ligament is stretched, reducing the medial longitudinal arch, reducing the height of the medial longitudinal arch. So this is the plantaria, and this ligament blends with the superficial part of the deltoid ligament. This ligament blends with the superficial part of the deltoid ligament. Alright. And the subtalar joint means what? It is the posterior articular area with the talus, articulation with the talus. In the this is the posterior articular surface on the dorsum of the calcaneal. Alright. This makes the subtalar joint. Subtalar joint কোথায় তৈরি হয়? এইখানে posterior articular surface of the dorsum of the calcanea with the talus, under surface of the talus. Alright. The subtalar joint বলতে আমরা এই জয়েন্টটাকে বুঝি। Subtalar joint we will understand this posterior articular surface of the calcanea. Right? Okay.